All right, well, we'll go ahead and get started. So thank you to all of you for joining. My name is Avash Kalra. I'm one of the transplant hepatologists here at the University of Colorado, and I'm the course director for this webinar series. I'm really excited to give today's talk entitled High Yield Updates from AASLD Guidelines, so the American Association for the Study of Liver Disease. This is the fourth out of five webinars that we have during this series for the calendar year 2025, and pretty soon we'll be coming up with a schedule for next year's webinar series as well. Just want to thank Lindsay Carter for all of her help putting this series together as well and for coordinating this. I'll go ahead and get started. I want to just point out that this webinar does provide free CME, so one AMA Category 1 credit. More information about this is on our webinars website. I have no disclosures to report for this, and neither do any of the planners or individuals controlling the content for this educational activity. There will be an evaluation that is required to be completed electronically. That's the QR code and link, but we'll also include this information in the chat and on the website. I just want to point out that the evaluation will close on Wednesday, September 24th, so that's 2 weeks from today. And as long as you complete the survey, then you'll receive the CME certificate the very next day. We also provide nursing credit for this as well, one contact hour through the University of Colorado College of Nursing Office for Continuing Education. And this information also is available on the website, and there will be a link sent for credit for this as well if needed. If you have any questions or need help with this, you can contact us directly or email. So just jumping right into today's topic. First of all, high yield updates in AASLD guidelines could be an entire week-long conference probably. There are 27 AASLD guidelines listed here, and some of them have not actually been updated in several years. Some of them have been updated within the last year or two. And I wanted to just focus on some topics of interest today from the guidelines that tend to come up in clinical practice, because I wanted to keep this as practical as possible, realizing that there's no way we can touch on every single guideline, obviously. There are also new guidelines coming out in the next few months that I'll touch on later as well. I want to also mention that we'll go through these objectives the best we can today. We'll review the management of patients with acute on chronic liver failure, specifically those who have renal failure. We'll develop a practical approach to using resmetirom, the medication FDA approved last year for treatment of patients with MASH and fibrosis. We'll discuss that, as this is now in guidelines as well. We'll understand the clinical utility of thromboelastography in assessing pre-procedural bleeding risk for patients with cirrhosis, and review indications for anticoagulation in cirrhotic patients with a portal vein thrombosis. If we have time towards the end of the talk, we'll also discuss second-line therapies for autoimmune hepatitis. So these are obviously, this is a wide variety of topics, so we are admittedly going to be jumping around between the guidelines. But to get us started, I want to focus on this guideline that was published in June of last year, so a little over a year ago, practice guidance on acute on chronic liver failure and the management of critically ill patients with cirrhosis. And I'll focus on renal failure, as I mentioned. But before I do that, acute on chronic liver failure. So this is a term that is applied to patients with chronic liver disease with or without cirrhosis, with extrahepatic organ failures in particular. Most of these patients require intensive care, and this presentation of what's called acute on chronic liver failure is really associated with significant mortality. So a precipitating event of some sort, such as, for example, alcohol-associated hepatitis, viral hepatitis, drug-induced injury, or even a non-liver related injury, such as a surgery, can lead to hepatic and extrahepatic organ failures, such as neurologic, respiratory, circulatory, or renal. To give another schematic about kind of what this means, starting on the left here, you have a patient with either chronic liver disease, cirrhosis, whether compensated or decompensated, and then there's this acute insult that leads to, in often cases, deterioration, systemic inflammatory response, and these organ failures that in some cases can be reversible, but in many cases are irreversible. And when that irreversible failure occurs, then at that point, there's a focus on either a liver transplant if the patient is a potential candidate and that would help their organ failures, or palliative care or hospice. So these are this measures a significant decline in these patients, and this acute on chronic liver failure is a structure or terminology to sort of discuss or apply our understanding of these organ failures to very sick patients. There are scores that it can account for extrahepatic organ failures, and I've listed a couple here on the screen. And those are actually recommended now in the guidelines over conventional cirrhosis-related prognostic scores, even the MELD score. The MELD score may reflect their intrinsic liver disease and therefore their intrinsic liver dysfunction, but it doesn't really take into account all of the other organ failures that can occur. So this is just as a quick example of using the CLIF-C ACLF score, ACLF standing for acute on chronic liver failure. This is on MD Calc, obviously, as you can probably recognize by the color and font. And there are various factors that go into this, and you can select, for example, what the bilirubin is, what the creatinine is, and other factors such as whether there's hepatic encephalopathy, whether they're on a ventilator, and so forth. And then it'll actually give you pretty good estimates of mortality at 1 month, 3 months, 6 months, and a year. So in the example that I just plugged in that includes some other factors that you don't see on the screen, 50% probability of death at 1 month, and that is something that's not necessarily reflected in a patient's MELD score. So these guidelines on acute and chronic liver failure from last year cover management and assessment of organ failures involving the brain, such as severe hepatic encephalopathy, cardiovascular organ failure, such as shock, respiratory failure requiring ventilation, for example, and renal failure. And I want to focus on renal failure because I think comes up a lot in the patients we take care of in the hospital, especially. And there are often questions regarding, well, how do we best manage these patients? And so to take a step back, acute kidney injury, just in general, occurs very commonly in up to 50% of hospitalized patients with cirrhosis, and even more prevalent in patients who are in the intensive care unit. Now, a unique cause of AKI in this patient population with cirrhosis is renal hyperperfusion leading to the hepatorenal syndrome. And I'll discuss pathophysiology briefly in a moment, but this is essentially the result of severe renal vasoconstriction. So, taking a further step back, before 2012, criteria defining AKI and cirrhosis were absent. And initially, there was this concept of hepatorenal syndrome being divided into two categories. This is the older terminology. Type 1 HRS was a rapid reduction in kidney function with an increase in serum creatinine to a level exceeding 2.5 per deciliter in less than 2 weeks. Type 2 is a more chronic deterioration in kidney function. And again, this is the older terminology. So a new definition of AKI, and this is sort of applied, broadly through the nephrology literature now, is how we think about this. So an increase in the serum creatinine level of 0.3 milligrams per deciliter or higher within 48 hours is an AKI, or an increase in the serum creatinine that is at least 1.5 times the baseline that's known to have occurred within the past 7 days. And so as a result of this changing terminology within the nephrology literature, as hepatologists have changed how we refer to HRS as well. So that acute form of HRS, what was previously called type 1 HRS, is now termed HRS AKI, and that's to distinguish it from the more chronic type that develops slowly, indolently over time, HRS2, previously now named HRS CKD. And it's important to point out that the new definition of HRS, so HRS AKI, eliminated the threshold value for the serum creatinine. So previously it wasn't HRS unless the creatinine went over 1.5, technically by the definition. And it's important to note that since we know already that the creatinine level doesn't necessarily reflect kidney function in many of these patients, and they have low creatinine, for example, due to low muscle mass to begin with. Just noting an increase in 0.3 or a 1.5 times increase above the baseline allows for an earlier diagnosis and treatment in patients who might have normal creatinine levels, but actually reduced kidney function. And so again, that tends to apply, especially, like I said, to those with sarcopenia, women, and older patients. The diagnostic criteria for HRS-AKI, just as review of this, is patients must have cirrhosis with ascites. Diagnosis of stage 2 AKI, which is basically creatinine or that is 2 to 3 times elevated from baseline. No response after 2 consecutive days of diuretic withdrawal and plasma volume expansion with albumin. And again, the recommended albumin dose is 1 gram per kilogram of body weight to a maximum of 100 grams per day. You also have to rule out other causes. So this is a diagnosis of exclusion. They are not in shock typically. And then absence of parenchymal kidney disease. So looking at their urinalysis, for example, and making sure that there's an absence of severe proteinuria, severe hematuria as well. You'll notice that this does not exclude patients who have a small, mild hematuria or proteinuria, for example. So those can still be present in these patients, but not the primary cause of their kidney disease. And then also no current or recent treatment with nephrotoxic drugs other than diuretics. So the pathophysiology of hepatorenal syndrome is also reflective of the pathophysiology of decompensated cirrhosis and severe portal hypertension. This is a busy slide, but it's a helpful one that sort of impressively, I think, in one slide or one figure summarizes the key processes from a pathophysiology standpoint involved in the development of hepatorenal syndrome. The key points being that in patients with cirrhosis who have, by definition, intrahepatic resistance, some insult, such as infection, bleeding, uh, significant volume removal, for example, leads to increased inflammation, so increased pro-inflammatory cytokines. That leads to splanchnic and systemic vasodilation, which again can be even worse, further worsened by sepsis or infection. This, as a result, leads to decreased effective arterial blood volume. And then the key point being here, the activation of neurohumoral systems. So that's the box at the bottom of the screen, where you can see that the activation of the renin-angiotensin-aldosterone system, the activation of the sympathetic nervous system, and the activation of the arginine vasopressin system lead to this constellation of sodium retention, ascites, water retention leading to refractory ascites and hyponatremia, and then progressive renal vasoconstriction leading to decreased renal blood flow and the hepatorenal syndrome. And so, from the AASLD guidelines, in patients with cirrhosis and AKI, after withdrawing diuretics and treating precipitating factors such as a bacterial infection, volume challenge with IV albumin at a dose of 1 gram of albumin per kilogram of body weight, maximum of 100 grams per day, is recommended for 48 hours. And if they do not respond, the patient has hepatorenal syndrome, AKI. Now, the mainstay of pharmacologic management of this has been the use of vasoconstrictors combined with IV albumin. And I want to focus on this part of the guidelines now because this is certainly something that has evolved in the United States, especially in recent years. It's important to note first, vasoconstrictors have not been shown to improve survival. So whether it be norepinephrine or any other vasoconstrictor, but their use should be considered a bridge to transplant, where it's not common that you're going to cure their hepatorenal syndrome with a vasoconstrictor, for example. Now, terlipressin, which is a vasopressin analog, is the most common vasoconstrictor used worldwide, and the predominant use for much of the last 10 to 15 years, especially, has been in Europe, where it's been available for some time now as the first line agent for hepatorenal syndrome. But it is now available in the United States and first line for the treatment of HRS. There have been 4 randomized control trials. I think it's important to know a little bit about the data behind terlipressin and also when to be concerned about its use and when to know for sure to use it. One of these trials was in Europe, 3 in North America, about 650 patients in total if you combine the clinical trials, and comparing the efficacy of terlipressin combined with albumin versus placebo with albumin. So the response rate varied between 36 and 44%, and that there are various reasons for that we don't necessarily have to get into with the constraints of today's time. Now, there's no difference in the overall survival or transplant-free survival between the terlipressin and placebo groups. The kind of landmark trial, especially for the Western use for in the United States, especially for the use of terlipressin, came from this study, New England Journal of Medicine, published in 2021. This is terlipressin plus albumin for the treatment of type 1 hepatorenal syndrome. And in this study, we found that there was a reversal of hepatorenal syndrome in 32. First of all, I'll point out, this is a small study. So 63 overall, we're talking about a group of a few hundred patients, and then in terms of what was found was verified reversal of HRS in 63%, 63 patients. That's 32% in the terlipressin group and 17% in the placebo group. So this was statistically significant. The patients who received terlipressin survived for an additional 10 days after the completion of treatment without the need for renal replacement therapy. And again, this small extension in survival may allow time for patients to receive a liver transplant. And that's the key here, to try and get them to the definitive therapy if it's available for them, or if they're a candidate for a transplant. Now, terlipressin can be administered intravenously as a bolus or as a continuous infusion, with similar efficacy. However, the cumulative daily dose and the incidence of adverse events are lower with a continuous infusion. And so it's typical at this point to use the continuous infusion rather than bolus therapy for terlipressin. And in particular, the adverse effect to be aware of is pulmonary edema and respiratory failure. So terlipressin was associated with an increased incidence of respiratory failure. This has to do with an increase in afterload, cardiac afterload that occurs as a result of terlipressin. And it's essential to withhold terlipressin and albumin if there is clinical evidence of intravascular volume overload, such as anasarca, JVD, hypoxemia, and especially pulmonary congestion or elevated right ventricular systolic pressure on an echo. Now, you might be wondering, well, what about octreotide and midodrine? Do we still use those? What's the data behind those? So again, just as a reminder, octreotide is a somatostatin analog. It acts as an inhibitor of glucagon, which is a vasodilator. And so as a result, you get vasoconstriction. And midodrine is an alpha adrenergic receptor agonist acting on vascular smooth muscle cells. And so the combination has been widely used in North America, because, again, until very recently, terlipressin was not available. And again, norepinephrine as a vasopressor must be administered in the ICU. And so midodrine and octreotide are available on the medical floors. But it's important to know that while reversal of HRS is possible, the combination works very slowly. And the combination also has weak vasoconstrictive activity. Octreotide alone is ineffective, same with midodrine. And there has been a randomized control trial showing that the combined treatment of octreotide and midodrine is inferior to terlipressin in terms of reversing hepatorenal syndrome. And so our advice at this point would be that these should really be only used temporarily for 24 to 48 hours, and only if terlipressin or another vasoconstrictor is unavailable or contraindicated. Well, what about norepinephrine? I've mentioned that a couple of times. There have been some small single center studies that have shown that the responses to norepinephrine are similar to those to terlipressin. Obviously, this requires a continuous infusion in an intensive care unit. And I mentioned the dosing there. Again, the goal of the vasoconstrictor therapy at HRS is certainly to try and increase urine output, and which is reflective of renal function in this case, but you want to increase their mean arterial pressure. These patients are hypotensive, and again, part of the pathophysiology is improving renal blood flow, improving that effective arterial blood volume, and doing that by increasing the MAP to over 10 compared to what they were before the vasoconstrictor. Well, what about renal replacement therapy? So renal replacement therapy, such as CRRT, dialysis, for patients with hepatorenal syndrome who are not candidates for liver transplant has been controversial because of high mortality and also the practical point that the underlying issue is not being cured. There's no consensus in the guidelines on when renal replacement therapy should be initiated in patients with cirrhosis and AKI. There have been several randomized control trials that have not shown a benefit of early initiation of renal replacement therapy in patients who are critically ill in the ICU. But again, those studies excluded patients with cirrhosis, or they were underrepresented in those studies. The expert opinion would be that in patients with cirrhosis, the decision about when to initiate RRT should be individualized. So certainly life-threatening indications for this, such as hyperkalemia or acidosis or severe uremia, may warrant initiation of a renal replacement therapy, or as a bridge to liver transplant, which is probably the situation where this comes up the most commonly in our center. If we think the patient has a path towards a liver transplant and would benefit from renal replacement therapy while waiting, again, as a bridge to that, then certainly it's appropriate to start. If they are not a liver transplant candidate and there's no other life-threatening indication for RRT, then perhaps should not be initiated just because of the practical reason that there's no end point, and then the patient is perhaps unnecessarily tied to dialysis or continuous renal replacement therapy without the option for a liver transplant. And again, liver transplant. So that leads me into this, is the ultimate treatment of choice in patients with hepatorenal syndrome. This is a separate talk talking about simultaneous liver kidney, but in some cases, depending on their essentially severity and duration of kidney dysfunction, these patients might meet criteria, which are now defined by the OPTN, for simultaneous liver and kidney transplant. Ideally, if a patient is a candidate for transplant and has hepatorenal syndrome, we want to transplant them earlier in that course so that they have higher chances of renal recovery after a liver transplant. If they don't have renal recovery, I will just mention that there is a safety net policy that gives gives priority to those patients with persistent kidney dysfunction after liver transplant, so that those patients don't have to, for example, wait years on dialysis while waiting for a kidney transplant. Those patients are prioritized to get a kidney transplant within the first year. And from experience, most of those patients get a kidney transplant 6 to 12 months after their liver transplant, if not sooner. So guidance statements, just to highlight some key points from this topic. So the use of terlipressin is indicated in hospitalized patients with stage 2 or greater HRS-AKI and without acute on chronic liver failure 3, meaning which essentially means 3 organ failures associated with acute on chronic liver failure. So the key to know there is that we wouldn't use terlipressin if someone has respiratory failure, but otherwise is indicated in these patients. Norepinephrine can be used as an alternative to terlipressin for patients with HRS-AKI and may be preferred in patients with shock. So they're going to be in the ICU already. You need to increase their mean arterial pressure, and that would maybe an ideal population to use norepinephrine. And then the use of RRT, as we talked about, should be individualized in these patients. In general, it's recommended if patients are being listed or being considered for liver transplant and have failed pharmacotherapy with vasoconstrictors. Moving on to just a couple of other guidelines that I want to highlight today. Well, first of all, we're not going to spend too much time on this, but I want to highlight just a practical guideline that comes up, I think, a lot in our general hepatology practice, and you'll see it in the hospital as well. There is an AASLD practice guidance on drug, herbal, and dietary supplement-induced liver injury. And I think that a key resource that I wanted to mention practically for when you're seeing patients and there's a question of drug-induced liver injury, again, from a prescribed medication or an herbal ingredient, is the liver tox resource, which is provided by the NIH. That's just a screenshot there, but essentially it's livertox.nih.gov. You can go to that website and type in a medication right into the search bar, whatever, or an herbal ingredient, or really anything that you're wondering may have caused a drug-induced liver injury. And then it'll provide data as well as case reports in many cases for that medication, as well as a likelihood score on whether or not it's been associated with drug-induced liver injury. It's a resource that I know we all use quite a bit in our practice. I also want to mention that this guidance also includes some recommendations regarding diagnosis and management of immune checkpoint inhibitor hepatitis, which is something we've seen a lot more of. Over 50% of patients with solid organ malignancies are put on immune checkpoint inhibitors now by oncologists. They are really, I think, amazing medications to as a potential treatment option for cancer. But a well-known side effect or adverse effect is development of a drug-induced liver injury from those medications. And so I would just want to mention this that there is guidance out there because this is a consult we get quite a bit in terms of management, and there's recommendations for how to manage that in this guidance. Now, I want to talk about this guidance as well. This was published just earlier this year. So, resmetirom therapy for metabolic dysfunction-associated steatotic liver disease. As a reminder, resmetirom is a agonist of a thyroid hormone receptor. It's the beta receptor, which is in the liver, believe it or not, though it's a thyroid receptor. And it's involved with triglyceride metabolism and other pathways related to accumulation of fat or steatosis in the liver. And it's been shown to improve not just steatosis, but also reversal of fibrosis. And we get a lot of questions in terms of who to use this medication in. This practice guidance, I think, is really helpful. And I wanted to highlight a few key points from that. So, patients with metabolic dysfunction associated steatotic liver disease. So, again, metabolic risk factors, oftentimes those are parts of the metabolic syndrome, such as obesity, diabetes, dyslipidemia. A key driving factor for many of those patients is insulin resistance. This is not recommended, okay, in patients who have cirrhosis, okay, whether that's confirmed on biopsy or some other form of non-invasive testing. It's also not recommended to be used in patients who have active thyroid disease. Worth mentioning that these patients were excluded from the trials just because of potential impact on thyroid disease, since this is a thyroid hormone receptor agonist. We also don't use this medication in people who have other active liver disease aside from metabolic dysfunction alone, and that includes alcohol use. I will say, just anecdotally, I've seen a couple of patients who referred to me and they're on resmetirom, but their liver disease is for alcohol-related steatohepatitis. So I would not recommend the use of this medication for that. There's no data for that. But it is recommended for patients who have MASH. So again, metabolic dysfunction, they have steatohepatitis on histology with stage 2 to 3 fibrosis measured either on biopsy or an imaging-based non-invasive assessment of fibrosis. And so that could either be done by vibration control transient elastography, and that's more commonly known as a fibroscan, measuring fibrosis, again, non-invasively, or an MRE, so a magnetic resonance elastography. And there's some recommendations in terms of where the stiffness measurement should fall in order to offer patients. So I think the most common place that you'll see this is a fibroscan or vibration control transient elastography. And the guidance recommends if their stiffness measurement, that's the kPa, it's measured in kilopascals, excuse me. If that falls between 8 and 15, then it would be recommended to try resmetirom. And again, the data suggests that in 20 to 30% of these patients, they'll have reversal of fibrosis by at least a stage. And this is the only medication that's FDA approved that has been shown to reverse fibrosis, which is impressive. And then it may be used, again, individualized decisions by a specialist of experience in liver fibrosis for values outside the recommended ranges or other data consistent with F2 to F3. I think this was just included in the guidance to leave a little bit of wiggle room, but I want to focus on the green box there, and that's what I would encourage you to do if you're considering using this medication. This is also a helpful chart from the same practice guidelines from the AASLD, and in terms of how to think about its use in the long run. I think there were initially quite a bit of questions in terms of how we should be using this as time goes on. So I think we understand that it should be used in patients with MASH and stage 2 or 3 fibrosis, but then what do you do? And so this helps with that question. It's important to monitor for safety at 3, 6, and 12 months. Now the resmetirom, obviously went through the rigorous FDA clinical trials and was shown to be safe as well as effective. Diarrhea and nausea are the most commonly reported side effects. There was an increase in clinically significant gallstone disease, but just having gallstones doesn't mean you can't use the medication, but that's just something to be aware of. And so, certainly monitor for adherence, safety, and so forth as time goes on. But then the key point here is deciding at 1 year whether or not to continue the medication. And so, if there is no response at a year, meaning there's a consistent increase in ALT, which is essentially a surrogate for more inflammation, more steatohepatitis in particular, or if there's worsening in their fibrosis measured non-invasively by a FibroScan. If there's no response at a year, then they're not likely in that group of patients who had benefit, and it's appropriate to stop the medication. But if there is improvement by greater than 25% in their liver stiffness measurement, on FibroScan or MRE, then it is appropriate to continue that medication. And ideally, they'll have had normalization or significant improvement in the ALT. I think that the less certain group would be the yellow box here at the bottom. So if there's a minor reduction in their stiffness measurement, if there's no improvement in ALT, then the benefit is uncertain. I would say that perhaps a biopsy may help you in that case in terms of getting more specific fibrosis staging, or reevaluating the strategy and deciding whether or not there's benefit. But perhaps giving it more time might be appropriate, especially if the biopsy points you in that direction. Okay. So far we've touched on briefly renal failure, acute or chronic liver failure in particular. We've talked a little bit about how there's a guidance for drug-induced liver injury, and we've talked about the resmetirom guidance. So now flipping gears entirely and talking a little bit about vascular liver disorders, bleeding risk, and portal vein thrombosis. And I've included this because these questions come up a lot. I got a phone call yesterday from a colleague in New Mexico asking about management of a portal vein thrombosis. And I think we get these questions a lot. And so I wanted to include this for, again, the practical guidance. So for bleeding risk, and what I want to get at here is how we assess bleeding risk in patients with cirrhosis. So first of all, it's important just to remember, again, this is a nice diagram from a publication from 4 years ago in Hepatology, that there are many types of bleeding in patients with cirrhosis, and this can be from, and different sort of mechanisms involved, right? So there's hemostatic failure and trauma, for example, dental bleeding, there's bleeding from puncture sites, actual mechanical insult and trauma leading to bleeding. And then there's portal hypertensive bleeding, so a pressure-related bleed, for example, esophageal varices that rupture or portal hypertensive gastropathy. A question that comes up is, well, is it safe to do a paracentesis in patients with cirrhosis? How do we assess their risk for that? Well, first of all, most patients in the United States who have ascites have decompensated cirrhosis, and most of those patients have an abnormal prothrombin time. So should we be looking at the PT-INR for this? Well, traditional tests don't really reflect the risk in cirrhotic patients. It's important to remember. And that's because, as I'll talk more about on the coming slides, there's a balanced deficiency in procoagulants and anticoagulants that it makes this population of patients different from a patient who is on warfarin for AFib. Okay, so that patient is anticoagulated and maybe has a bleeding risk. But patients with cirrhosis actually have, again, like I said, a balanced deficiency of procoagulants and anticoagulants, and that's what's making their prothrombin time abnormal or elevated. And so there's no data supportive cutoff of coagulation parameters in terms of the traditional tests. Serious complications from a paracentesis in particular are really unusual. You may remember the 1 in 1,000 that has had a bleeding complication, but the reality is it's the risk is less than that, and that's been shown in multiple studies. So again, should we use the INR to assess bleeding risk? Well, this was published at ASLD or presented at ASLD a couple years ago. There are dozens of studies affirming the lack of utility of an INR and accurately predicting procedural bleeding, and that includes in many areas in medicine. So for dental extractions, bronchoscopy, coronary artery catheterization, that's in the cardiology literature. It's been published in the hepatology literature that there's lack of utility of INR for assessing risk for liver biopsy, for therapeutic paracentesis, even for colonoscopy with polypectomy. And so this is just not a useful test for our patients, even though it's perhaps the most commonly available test. Um, I mentioned earlier that the INR was designed to monitor individual patient responses to patients on a vitamin K antagonist, such as warfarin. But there are changes in cirrhotic patients, again, on the left here, the top part, changes that promote bleeding and changes that promote clotting. And patients who with cirrhosis have low levels of factors 2, 5, 7, 9, 10, and 11, but they also have low levels of protein C and S and antithrombin, and that balances each other out in terms of their risk of actual bleeding. And so this shows it again just graphically that we have a hemostatic normal balance between clot formation and clot breakdown. And we can achieve this balance in liver disease as well, and often do. It's important to remember that these patients have a risk of clotting just like they have a risk of bleeding. And I'll get to the portal vein thrombosis as well. But again, just to re-emphasize the point, just because their INR is 2 doesn't mean that they're prevented from a clot, right? They're not anticoagulated. Those patients get clots quite commonly, in fact. Um, so there's no data to support that an INR less than 1.5 is safe for a procedure, even though there's wide acceptance of that. And I think this is kind of one of the pet peeves of any hepatologist if we're told to lower their INR to under 1.5 for a procedure, since there's no data for that. So just to be safe, should we give FFP, fresh frozen plasma, to lower the INR? Should we just do that anyway? Well, prophylactic transfusions, it's important to remember, may expose patients to increased risk of adverse effects. And so I would argue that we shouldn't just be giving FFP to lower their INR to sort of appease a proceduralist. There's risk of transfusion-related acute lung injury and exacerbation of portal hypertension, and there's really no protective effects of that. There's also, key data that in a patient with an active or recent variceal hemorrhage, if you're giving FFP, that can worsen the variceal bleed by increasing plasma volume even further. So again, no protective effect and potentially even harm to doing that in the setting of bleeding, for example. I mentioned this already, but again, these patients are at risk for portal vein thrombosis or DVT despite the quote unquote high INR. And so the guidance statements for this, due to conflicting data in the literature, current guideline recommendations from the AASLD do not suggest a specific INR or platelet cutoff where procedural bleeding risk is reliably increased. And the AASLD does not recommend routine pre-procedural correction of INR, platelets, or fibrinogen. Of course, in reality, in practice, determining procedural bleeding risk is complex, and perhaps there are factors. If the platelets are under 10 or 20, perhaps the bleeding risk will be higher for a major procedure. And so it requires collaboration between specialists to determine the level of bleeding risk between these procedures. There's a kind of a helpful guidance to this that describes low risk and high risk procedures in patients with cirrhosis. And high risk is determined or defined as any procedure with a baseline bleeding risk over 1.5% for that procedure. And so you can see here on the left that common procedures that are done in these patients, such as a paracentesis and thoracentesis, are considered low risk. And I'll even point out that a coronary angiography and right heart cath are considered low risk. So they have baseline bleeding risks under 1.5%. Now, a biopsy of the liver, tumor ablation, placement of a TIPS certainly has higher bleeding risk, and so may require additional conversation between specialists in terms of the best techniques or risk reduction methods to be used. This is a continuation of the same chart. So lower risk procedures include diagnostic EGD, even routine variceal band ligation, I'll point out, is considered low risk. Diagnostic bronchoscopy, colonoscopy, including biopsies. So these are common procedures that you'll see. Higher risk would be colonoscopy requiring polypectomy. Dental extraction is another common one that comes up, and so that might require additional risk reduction. Now, do we have more helpful tests, though? That's the key to assess pre-procedural bleeding risk. I talked at length already about how useless the INR is for this. And so I want to point out that there is available viscoelastic testing, thromboelastography, or TEG. So this is a complex slide. I'm not certainly not something you have to commit to memory. I just want to point out just what TEG is, or thromboelastography. So briefly, it's a test in which a small sample of blood is taken from the patient. It's then rotated gently, essentially, to imitate venous blood flow sluggishly and activate coagulation. So by spinning the blood, coagulation cascades are activated. Okay. And there's a thin wire probe in this device that's used for this test around which the blood is rotated. And clot forms around that thin wire probe, which is then measured. So they can measure the speed and strength of clot formation in various ways by a computer. This is not something done by one person. The speed at which the sample coagulates depends on the activity of the plasma coagulation system, platelet function, fibrinolysis, and other factors which can be affected by medications and other things. And so four values, okay, that represent clot formation are determined by the test. So there's the reaction time, which is the R value. There's the K value. Um, and then the angle excuse me. So the K value is, well, let me list the variables first, and then I'll explain what they are. So there's the R value, the K value, the angle, and the MA, which is the maximum amplitude. So the R value is the time until the first evidence of clot is detected around that wire probe. The K value is that from the time from the end of the R until the clot reaches 20 millimeters. So basically, this represents speed of clot formation. The angle is sort of the tangent of the curve made as the K is reached and offers similar information to the K. I don't think that's particularly helpful. And then the MA, or maximum amplitude, is the reflection of the clot strength. So the maximum amplitude is actually probably the most helpful. I'll get back to that in a second. But thromboelastography guided blood product use before invasive procedures in cirrhosis has been studied. This was a randomized clinical trial published in Hepatology where patients in the TEG group got a thromboelastography to guide blood product use versus standard of care. And you can see that patients in the TEG group received much less blood products. Okay. INR, by the way, ended up being like the same between the groups. That wasn't statistically significant. You can see the TEG group receives 6 units of platelets versus 78 units in the standard of care. Again, the platelet level ended up being similar. There was no significant difference between procedure-related bleeding or transfusion reactions, but it's notable that no patients in the TEG group had procedure-related bleeding, and no patients had transfusion reactions, whereas one patient in each of those categories did in the standard of care group. Again, there were 30 patients in each group. So this was published in 2021 that showed similar findings, but the key to this was that the maximum amplitude, so that MA value from the TEG was probably the most helpful value. So all patients who had a maximum amplitude that was low, meaning low clot strength, under 30 millimeters, had major bleeding. And so that's a key that I think is helpful to think about when you're talking about procedural bleeding risk. If you can get a thromboelastography and their maximum amplitude is low, they probably have high risk for bleeding and may warrant even not doing the procedure. So a related topic to this that's also covered in the guidelines is, should I start my patient with cirrhosis and a portal vein thrombosis on anticoagulation? Okay. Now, I will note that we're talking about patients with cirrhosis for the purpose of this, but if a patient does not have cirrhosis, anticoagulation is recommended in most, if not all cases, to prevent development of portal hypertension. So I'll just mention that as a caveat. So portal vein thrombosis, patients with underlying cirrhosis and portal hypertension, first of all, Congestive intestinal ischemia in these patients who develop portal vein clot is actually much less common than maybe many of us would think, and certainly is less frequent compared to patients without cirrhosis. And that's due to the presence of portosystemic collaterals. So they're less at risk for developing mesenteric ischemia from a portal vein clot. Um, so patients without ischemic symptoms, the aim of the treatment is to prevent portal hypertension development. Excuse me, the aim of treatment is not to prevent portal hypertension development. That already exists in these patients. But it is to prevent worsening and to avoid progression of thrombosis that might hinder a future liver transplant. For the community, I want to emphasize that if a patient has a thrombosis extending throughout their mesenteric vasculature, into their SMV and splenic vein, it's very common that those patients can't get a liver transplant. The transplant surgeons do require some open vasculature to perform the anastomosis to the new allograft at the time of a liver transplant. And so if there's clot everywhere, there's really no target for that, and it can prevent or preclude a liver transplant. So we want to prevent that from happening and avoid progression of thrombosis. And so that may be an indication for anticoagulation. Um, we would still manage complications of portal hypertension just like any other patients of cirrhosis. It is unnecessary, based on the guidelines, I want to emphasize this, to delay anticoagulation until variceal eradication. Now, ideally, you would know if the patient had had large varices before starting an anticoagulation for a patient with portal vein thrombosis. But you don't have to. And I wouldn't start it if someone just had a variceal bleed. But keep in mind that if someone has occlusive portal vein thrombosis, treating it and reduction of the clot may improve the varices size and actually lower the risk of bleeding rather than increase the risk of bleeding. So in patients with cirrhosis, existing trial data are weak regarding the treatment indications um, for a portal vein thrombosis. The key here is that while we may use anticoagulation in someone who to preserve their vasculature for liver transplant, as I mentioned, the guidelines will recommend basically classifying these patients as non-occlusive or occlusive portal vein thrombosis and making a decision there. So if a patient has minimally occlusive recent thrombosis of the portal vein or small intrahepatic subbranches of the portal vein, um, who is not being listed or pursuing liver transplant, then observation with serial imaging is appropriate based on the guidelines. So treatment for progressive clot should be considered with anticoagulation, but for, again, minimally occlusive thrombosis or subbranched portal vein thrombosis, you don't have to anticoagulate. Now, if they have recent occlusive or partially occlusive greater than 50% of obstruction, then antithrombotic therapy should be considered, especially to prevent progression and allow for liver transplant at a later date. Um, Now, in patients with chronic complete occlusion of the main portal vein or cavernous transformation of the portal vein with established collaterals, there's no established benefit of anticoagulant or interventional therapy, and the treatment in that case should be targeted at managing portal hypertensive complications. Um, a related topic to this, and this is just only one slide on this topic, but the AASLD practice guidance on risk stratification and management of portal hypertension and varices, excuse me, in cirrhosis was published last year in May, and covers additional topics in terms of variceal surveillance. The one key guidance that I wanted to include for the purpose of today's talk is that carvedilol is the optimal and recommended preferred non-selective beta blocker in the treatment of portal hypertension in patients with cirrhosis. Okay, so the recommended maintenance dose is 6.25 to 12.5 milligrams per day. Now, just as a reminder, the beneficial effects of non-selective beta blockers in portal hypertension are derived from their ability to decrease portal pressure, and that's through a reduction in portal and collateral blood flow. And that is achieved by decreasing cardiac output, so that's beta 1 blockade, but also splanchnic arterial vasoconstriction, that's beta 2 blockade. Now, carvedilol has additional alpha 1 adrenergic activity and sort of facilitates the release of nitric oxide, further reducing portal pressure by inducing vasodilation of the intrahepatic vasculature. And so it actually allows for a significantly more pronounced decrease in the portal hypertension than traditional beta blockers. Other guidelines that are available through the AASLD involve management of primary biliary cirrhosis, primary sclerosing cholangitis, treatment of alcohol use disorders, and treatment of viral hepatitis B and hepatitis C. Um, it would take me probably several hours to go through each of those today, but I wanted to point out that in our webinar series last year, we covered these topics. My colleagues, Dr. Foreman, Dr. Norvell, Robin Bricker-Ford, one of our excellent pharmacists, gave talks through this webinar series, and I just wanted to give a shout out to those talks in particular because it covers a lot of the guidelines from the AASLD. And those videos are available for free on our webinar website. You can go back and refer to them anytime. And I think they're really good talks that cover those guidance. Now, I mentioned at the beginning that we would only cover autoimmune hepatitis if we have time. It is 12:51, it looks like, Mountain Time. And so I'm not going to spend all of the time on this last and final guideline, but I gave a talk recently in Santa Fe. And if any of the group from there is on, this talk was just last week, and there were a lot of questions about autoimmune hepatitis. And I wanted to just mention that there is practice guidance in terms of managing this condition. I'll touch on just a couple highlights, but I'm not going to cover every slide I've included just for the sake of time. Just briefly, autoimmune hepatitis is an autoinflammatory liver disease, chronic, progressive, immune-mediated, driving from multiple factors, and should be considered in all patients presenting with acute or chronic liver disease. Most patients are female. There's a bimodal presentation, second and fifth decades of life. The latter decade is likely related in part to sort of later diagnosis, and as a result, many of these patients have cirrhosis at the time of presentation. Um, Basically, there's a break in self-tolerance of our CD4 and CD8 T cells, and essentially they start thinking that antigens within the liver are foreign, and there's a subsequent absence of B cell inhibition, and these autoreactive B cells produce autoantibodies that lead to essentially attacking our own livers and increasing inflammation, and that's autoimmune liver disease. There's type 1 and type 2. Type 2 is rare and more common in childhood and early teens. This is the condition that's associated with the anti-liver kidney microsome antibody. You really don't have to check that antibody in patients who are older. For example, cirrhosis at that age is rare, but in type 1, traditional classic autoimmune hepatitis presenting in adulthood with the typical antibody positivity of the ANA and smooth muscle antibody, cirrhosis is quite common in up to a third of those patients. Most of these patients present with fatigue, but otherwise can present asymptomatically with elevated liver enzymes. And recognition of acute liver failure at presentation is critical. I want to point out that a small percentage of these patients will require early liver transplant and severe autoimmune hepatitis that leads to, for example, massive necrosis of the liver parenchyma. And it's important to recognize that and potential futility of early treatment, risking for example, high dose steroids in a patient with a fully necrotic liver who would just benefit from a liver transplant. I'm gonna, for the sake of time, skip over the diagnosis slides here and get to the treatment because a lot of questions come up in terms of managing these patients. So treatment, certainly oral glucocorticoids and thiopurines are the first line treatments for autoimmune hepatitis, but there are other medications. And I think we get a lot of questions in terms of, well, what other things can we use other than prednisone and other than azathioprine, for example? Response to therapy is important, so that's gauged by monitoring improvement and ideally normalizing the liver enzymes and IgG levels. It is important just before treatment if you can, remember to check the thiopurine methyltransferase or TPMT activity. This detects individuals who are at risk for severe myelosuppression from azathioprine. This is low or absent TPMT activity is actually quite rare, less than 1% of the population, but it's important to screen for this regardless. We'd encourage making sure the patients are certainly vaccinated against hepatitis A and B. Understanding their risk for osteoporosis is important because of the likelihood of some degree of steroid use. And screening for celiac and thyroid disease, given disease overlap, is recommended in the guidelines as well. So first-line treatment of autoimmune hepatitis. This chart is from the diagram. This diagram, excuse me, is from the guidelines. It's a bit of a busy slide, but want to emphasize a couple things. On the left, autoimmune hepatitis. Initial treatment involves induction therapy. So prednisone, 20 to 40 milligrams per day, or prednisolone as an alternative, especially if the liver enzymes are 10 to 20 times above the upper limit of normal. And then after 2 weeks of steroids, it's appropriate to add azathioprine. There's no need to wait until the enzymes are normal to add azathioprine. I wouldn't start them at the same time just because of the risk of side effects, adverse effects, and so forth if you start multiple medications at the same time. But what's recommended in the guidelines is if you're seeing improvement in their liver enzymes 1 to 2 weeks after the start of a steroid, whether that be prednisone or prednisolone or budesonide, starting at the dose of 9 milligrams daily, then you can start azathioprine again 2 weeks later. Do not use budesonide which is in the middle part of this diagram in patients with cirrhosis. There's a risk of portal vein thrombosis in patients who have cirrhosis. And so we would not recommend budesonide, but still can use prednisone, can still use azathioprine. It's important to continually assess their response, taper the prednisone or budesonide over the next 3 to 4 months, ideally, and then achieve remission, ideally, with steroid withdrawal and continuing azathioprine long term. Now, typical starting dose of azathioprine is 50 to 100 milligrams daily in adults. Evolving leukopenia or thrombocytopenia that are severe would warrant dose reduction or drug withdrawal. And azathioprine should be discontinued if the cytopenia does not recover in 1 to 2 weeks. Now, I mentioned I wanted to talk about second-line therapy. So treatment failure does occur in up to 10% of these patients. And that treatment failure is associated with increased risk of progression to cirrhosis and liver failure, with mortality rates as high as 30%. So second-line therapies for treatment failure include MMF, which is mycophenolate, or calcineurin inhibitors, and less commonly mercaptopurine and biologics. So the AASLD does suggest a trial of MMF, so mycophenolate over tacrolimus, as the initial second-line agent in patients with autoimmune hepatitis. Now, in patients who received MMF in a meta-analysis, 425, excuse me, 58% of the patients had response, and in patients who had azathioprine intolerance, that was even higher at 82%. They were well tolerated, adverse event rate of 14%, and discontinued in about 8%, usually for GI side effects such as diarrhea. Worth mentioning as well, of course, that a lot of these patients I mentioned, are female, they're younger, and so pregnancy counseling is important. Ideally, biochemical remission should be achieved 1 year prior to conception. There is an association between an autoimmune hepatitis flare and prematurity. Mycophenolate is contraindicated during pregnancy due to its teratogenicity. There's also risk of flares in the postpartum period because there's some transient immune suppression that occurs during pregnancy. And so women with autoimmune hepatitis should be monitored closely for 6 months after delivery. And if a patient is being put on MMF, really should ensure a negative pregnancy test and at least 2 effective methods of birth control. Non-invasive fibrosis testing is also touched on in the AASLD guidelines. I think it's common now that FibroScans are more common. I think it's easy. Well, it's obviously easier to get and lower threshold to get them. But it's okay to wait a little bit in a patient you've just diagnosed with autoimmune hepatitis because the accuracy in actually quantifying fibrosis is impaired if you get a FibroScan within the first 3 months of treatment. And that's simply because liver stiffness, as estimated by elastography, is affected by inflammation and fibrosis. And so after at least 6 months of successful immunosuppressive therapy, it's appropriate to get a FibroScan at that point to accurately diagnose cirrhosis and distinguish advanced stages of fibrosis from less severe stages. I'm going to skip that slide. Coming soon, there are more AASLD guidelines. I'll admit that when we came up with the schedule for this year, I thought these guidelines might be out by now, but they're not. The AASLD is currently putting together guidelines for candidate evaluation for adult liver transplant, as well as post-transplant management of non-graft related complications in the adult liver transplant recipients. So those are coming soon from the AASLD. So we covered a lot in terms of different guidelines today. That is the website for our webinar series. We have one more webinar later this year focused on liver transplant surgery. Wanted to share my cell phone and contact information. That's how you can get a hold of our clinic as well in terms of referrals for our clinic or outreach. I've listed some outreach locations that we have, and that includes going all the way up to Montana and down to New Mexico. Thank you very much for your time. I know that I did take essentially the full hour, but I'm happy to stay on and answer any questions. Really appreciate everybody joining today. I'll point out, so first of all, couple things. You are welcome to put a question in the chat. In my experience, a lot of people will reach out afterwards, and so you're welcome to reach out by phone or email to me at any point if you have a question or any feedback for that matter on the webinar series. Want to also just point out that all the information for the CME and nursing credit is on the website. Lindsay Carter has put that in our chat. And then lastly, like I mentioned, we're going to be putting together the webinar series for next year. And so if anybody has any topics that they're interested in hearing from our faculty here, please let us know in any format you'd like in terms of topics that you'd like to see covered in next year's webinar series. Okay. Well, with that, thank you again. I hope everybody has a great day and appreciate your attention.